Hi, so my project was mainly based around bed sores and trying to prevent them via sensors and lights using a new innovation. But aside from that, I did do some shadowing, and that was a major portion of my project. So I'm going to talk about it, but it is kind of separate. So I shadowed Dr. Potts at Goodman and Campbell Brain and Spine, and I watched several neurosurgeries. He is a spine specialist, so I watched two fusions, and I watched a multi-level spinal reconstruction. So basically, as far as the fusions, they're a little similar, but just because one of them is more levels than the other, they really just consist of removing facet joints and intervertebral disc from the spine, so removing bone and disc from the spine, and then placing in pedicle screws above and below kind of like the ailment area, and then placing in bone graft via cages. So these screws and rods are temporary fix, as the spine does need to create new bone in order for this procedure to be successful. So the other procedure that I saw that was a fusion was an anterior cervical discectomy. And this is similar in the sense that the disc is removed from the spine, and then bone graft and implants are placed on the inside, and then on the outside, this one is a little different because instead of using pedicle screws, a quadrilateral kind of cage-shaped brace is put in and screwed in order to keep the shape. On another side of things, I also saw a reconstruction with adult spinal deformity, which is basically scoliosis. And this one was their longest and most invasive procedure, removing a lot of spine and placing really, really long rods all the way down the back in order to maintain the structure. So when asking the surgeon about kind of what this entailed, he compared the spine to a skyscraper. And I really like this comparison because it really highlights how rods and screws are similar to scaffolding when you're building a skyscraper. They are only temporary, but the inside must be built in order for that scaffolding to really have served its purpose. So on the other end of things, I work as a CNA at Copper Trace. So I wanted to focus a little bit on bed sores because they are pretty prevalent in what I've seen. So about 1 in 10 facility residents experience bed sores, and every 9 minutes somebody dies because of bed sores. And I'll go into that a little bit in a second. So basically, a bed sore is a pressure injury or ulcer that occurs after sitting or laying down for a prolonged period. So especially in your bony areas, blood capillaries can become occluded a lot easier, and blood flow can be restricted. So when you put pressure on it for a long time, capillaries are occluded, blood becomes restricted, and that thus the area becomes deoxygenated, and this causes skin to die. So this happens in stages, and it eventually goes deeper and deeper, eventually extending to the muscle or bone. And this can take up to 3 months to 2 years to heal. This can become deadly because bed sores are an open door for bacteria and infection. So once in the wound, infection can lead to sepsis and septic shock. So basically the immune system is going to trigger inflammation, blood clots, and leaky blood vessels, and thus internal organs can die, tissue can be damaged, and death can occur. So some contributing factors into bed sores that I would like to focus on are friction and moisture. So friction can kind of become an issue when you are moving people really often, especially unnecessarily on an already irritated area. And moisture can occur when people are left in dirty briefs for too long. So briefs are kind of like diapers. If people are incontinent, then they need to use something in order to catch the output. So basically, when your skin has too much moisture on it for an extended period of time, something called maceration happens. So this happens to everyone. You know, when you get in the shower and your fingers become wrinkly, that's maceration. But when it occurs on an ulcer, it's just more severe because it makes it more susceptible to pressure and friction, and it weakens the skin barrier. So some current solutions are turning and repositioning, sitting upright, and providing padding. And some commercially available innovations are bed sore cream, turning devices, etc. But I wanted to focus more so on keeping the area clean and dry. So my inspiration for this was a pressure sensor that used a sleeve and an app to communicate back to the healthcare provider. and then a bed sore evaluator that used a combination of indicators in order to evaluate the situation. So my idea was a heat sensor that will be tucked into a color changing fabric that changes color when it's wet, and it's going to be adhered to a problem area, most often the buttocks, as that is an area that can become easily wet, and as that is a frequently seen area with bed sores. So basically, based on the type of heat sensor based on the type of based off of the type of signal that is sent from the heat sensor, the healthcare provider would know whether it is time to reposition or change the person. So if it is time to change them, then a specialized call light, which was yellow, will be sent to the call light system, and this can only be turned off by charting the qualities of the output. So this would allow for higher accountability also amongst the healthcare professionals, and ensure that residents don't stay in soiled briefs and avoid unnecessary changing and thus friction.
Okay, good job.